I'm Daniel Minty, a cognitive behavioral therapist, teacher, and writer. Most of us realize our thoughts and behavior create states like anxiety and depression. Many of us don't understand how these same inputs create and maintain physical pain. As a result, we misperceive ourselves as passive victims of pain, failing to see how and why we create this vital human experience. In a recent class at Georgetown University's Integrative Medicine program, my students and I looked at the ways mind and body work in concert to produce pain. Precisely the same stimulus or degree of tissue damage may or may not create a pain experience. We examine how this happens and at what we can do cognitively and behaviorally to reduce or eliminate chronic pain states. Please join us. So for the rest of this class, we'll be looking at another human experience that we create both cognitively and behaviorally, as we would create the experience of depression or panic. In this case, we'll be looking at the experience of pain. And this first slide might be somewhat challenging if, like me, you have perceived pain as being an enemy, as a bad thing that should be avoided and we should be fearful of. I'm going to suggest to you that pain is actually our best friend. The language itself makes this a little more difficult to see. So the word comes to us from the Latin poena, which described a penalty that followed some transgression. So the roots of the English word say pain happens if we do a bad thing, which lends us to consider pain an enemy of some kind, or a consequence that we would hope to avoid. What the new science that's been developed over about the last 20 years has shown us pretty convincingly, pain is not an enemy. It's our most powerful guardian. That the pain experience will immediately and dramatically change things like what we're thinking and those things that we're doing, and a lot of other parts of our physiology as well. So if I'm walking in a field and I turn my ankle, my thoughts, which might have been going in the direction of, well, I wonder where I'll go next, or isn't this a lovely early spring morning in the Southern Rockies, are going to experience a hard reset. And my behavior will immediately and dramatically change. I'll be having thoughts like, is it broken? And I'll stop walking. And when I start walking, I'll probably limp. My endocrine system will change dramatically, probably experience a rush of cortisol, adrenaline, other alert, sympathetic neurotransmitters, My breathing will change, and I'll have an immune response. My immune system will start sending cells to my ankle to produce swelling. So all of these hard resets are in the service not of making us hurt, but in healing and protecting us. If I did not have that pain experience, and let's say I had broken my ankle or torn my Achilles tendon or something like that, and my thinking stayed the same. Oh, this is a lovely day. I think I'll start skipping and running through this field. You could see how those choices might further endanger my physical and eventually emotional wellness. If I'm treating an injured ankle as though it were healthy, probably going to do more damage and create a problem that I don't yet have, but might. What happens in that moment of pain? What happens is that nociceptors in the peripheral nervous system, in this case, the tissue in my ankle, send signals to my spinal cord that are relayed to my brain. So we used to talk about pain messages. We don't say that anymore because we understand that messaging is perhaps entirely irrelevant to the pain experience. It's not a pain message, it's a danger message. The word comes to us also from the Latin, nocere means to harm. So those nociceptors, those nerve cells that sense potentially dangerous changes in tissue, in this case, at least pressure changes, can also include temperature changes. If we're approaching a hot surface, those nociceptors will start ringing those danger signals, sending those to the brain, again, in an effort to change our thinking and our behavior. Other sensors are measuring the acidity in our environment. So if out in that field, I brush against a stinging nettle, say, those sensors will light up and send a message to the brain, danger here in the skin of the left calf. Oftentimes, the inflammatory response will create this condition of acidosis. And in chronic pain states, we're walking around not with an ankle that swells up for a few days, and then once the healing has occurred, returns to a normal condition. But we're walking around on what are otherwise pretty healthy ankles, pretty healthy body, but in this state of inflammation, those acid nociceptors will continually and chronically send messages to the brain, danger. And those neurons that fire together will begin to wire together and will experience our entire life as being a dangerous and potentially a painful existence. Much of the work that I'm presenting comes from the NOI group that I mentioned earlier, David Butler and Lorimer Mosley. They have been researching the phenomena of pain for 25 or so years now. Wrote a book that I'd recommend if you're interested in understanding more about this thing we call pain, called Explain Pain, which the second edition came out in 2013. So these danger messages or action potentials, it's like chemoelectrical activity at the cellular level, originate in these peripheral nerve cells and travel to the spinal cord. The next stop are the dorsal root ganglion, which are specialized nerve cells. We could call them mini brains. It's like the most peripheral structure of the human brain. And those cells sort through that messaging. Some messages the DRG might decide not to pass on to the brain. They would decide, no, that's not important information. Brain doesn't need to get that. Some messages, the DRG might say, these are critical. We need to get these to the brain now. And the DRG would facilitate an accelerated transmission of those messages into the brain. This spinal cord is a two-way street. So just as the peripheral nervous system sends information up to the brain returns messages down the spinal cord into the DRG and out to the peripheral nervous system. One of the responses the brain may make is the release of powerful modulatory hormones that immediately and very powerfully can downregulate the DRG messaging. So the brain may decide it's very important for a chemical like opium or serotonin or endogenous morphine to get administered to the DRG to turn off or turn down the messaging. If there's massive signaling coming in from the peripheral nervous system and the brain perceives it's a bad idea for that messaging to emerge as the output pain, the brain will create the opposite response. Understanding the reciprocity here is an important part of understanding the pain experience. This is a two-way street. It's a conversation between the peripheral nervous system and the central nervous system. And that conversation is happening in real time for all of us. And hundreds of thousands of messages per moment are being transmitted, either up or down the spinal cord. So perhaps you're beginning to appreciate that nociception are danger messages, not pain messages. And nociception is neither sufficient nor necessary to create the experience of pain. I'll say that again because it's the crux of the matter. Danger messages from the peripheral nervous system are neither sufficient nor are they necessary to create this experience that we call pain. In our first book, I tell the story of a combat veteran that I worked with. Had experienced a lot of PTSD symptoms for a long time. And he told me the story of being in a firefight. His unit got overwhelmed and they managed to get out but there were a lot of casualties and injuries. So once he'd gotten his troops out of this firefight, a paramedic came up to him and said, "Bob, where's all the blood from?" And Bob said, "What blood?" And he looked down, and the bottom half of his body was drenched in blood. And he said, "I don't know, somebody must have, gotten hit. Maybe it was that guy who was carrying." Well, Bob had been shot. He had 3 bullets in his back. He experienced no pain until 2 days later when another medic was changing the bandage. So the bullets had avoided vital organs. They hadn't broken his spine. But you can imagine that having 3 military-grade bullets in your body would set off some serious alarm messages. Those messages did not create an experience of pain. And you could ask yourself, why not? Why did Bob's brain receive the messages, evaluate them, and decide pain is not going to help Bob in this moment? Neither is nociception necessary to create sometimes intense pain. Many examples of this. Lorimer Moseley designed an experiment where he told patients that he had this stimulator that sent electrical current through the brain. And they agreed to get hooked up to the stimulator, put electrodes on their heads or something. And then they would watch as a dial was turned. And the dial went from some minimal voltage to a rather high voltage. Now, as the dial turned, these people obviously began to experience pain. And the pain was relative to the position of the dial. The higher it went, the more pain the person experienced. Well, what they didn't know was that there was no current at all running anywhere. So there were no danger messages coming in from the peripheral nervous system. But the experience of pain was absolutely real and reached relatively intense place for some of the participants. Another way that pain arises without nociception being present is phantom limb pain. I've worked with patients who were in accidents and lost part of their limbs, and then for years afterward would experience pain in empty air. Finally, there's this phenomena we call cognitive viruses. Thoughts themselves will create an experience of pain, including the concomitants of that experience, swelling, the skin turning red. If a person has had a chronic injury, say broken a vertebrae in their back, simply imagining moving in certain ways can create sharp and intense pain in that body and mind. And you could ask yourself, why would the brain do that? Why would the brain continue to create a pain experience free of any nociception in a limb that was no longer there? Why would the brain take the mere imagining of a physical movement and create sharp pain associated with it? So I hope that you're beginning to see that this experience of pain contains strong motivational factors. And in that way, it's like an experience of vision. We will get data up our optical nerve into the brain, a lot of data. And those neurons, those sensory cells, will present a picture of what's out there. What we will actually see is the result of a decision that the brain makes. And it's typically made relative to what does the brain perceive it's important for us to see. We'll ignore all of that other data and just focus and report seeing what the brain has decided is most important for our safety, our wellness. Oftentimes in a threat state, we'll experience what's called tunnel vision, where the rest of the data drops out. And all we see is that Western diamondback rattlesnake that I was about to put my foot down on. So, in fact, the experience of pain is in our heads. Our peripheral nervous system will send danger signals into our heads. But those are danger signals, those are not pain signals. The brain will evaluate this data instantaneously. This is probably the brain's most important job. Take that data and know right now what it means. And right now, produce that output that may or may not include the experience of pain. It will also produce multiple other outputs related to what we will now think, how we will behave, the composition of our endocrine system, an immune response or lack of an immune response, the sympathetic nervous system responses. And all of these travel together. We could say that they're less distinct individual responses than a tableau of response that has cognitive, behavioral, endocrine, etc. components to it. This happens quickly and very, very powerfully. Wanted to give you a trigger warning before I shared this next slide. And I would invite you to notice what happens in your body and brain when you get that input from my body and brain. I want to give you a trigger warning. The image I'm going to show you next could be somewhat upsetting to some of you. And now I'm going to show you the image. And again, notice what happens in your body and brain when your brain gets this new data. new information arriving in your visual cortex. I filmed this picture because I wanted to give you, in part, an emotional response to a story I'm going to share with you. I grew up running, put a lot of miles on my body by the time I was in my mid-20s, and was also skiing and pole vaulting and asking my body to do a lot of somewhat stressful things. So as a result of that, I developed a flap tear in the meniscus of my left knee. This is an injury that creates a little finger of tissue. And that finger of tissue can create irritation when the knee is used. So I wanted to keep running. I very much liked the effects that it had in my body and brain. And I just accepted I will have pain in my knee when I run. I changed my behavior a bit, ran less quickly, but wanted to keep running. I was in graduate school in Heidelberg, Germany, and lived out near Weinberg, vineyard there. Had some nice trails that ran through it up into the woods. And after school, I'd go out and I'd run a few miles. And there was a farmhouse on the route that I ran by every day. And there was a dog that looked a lot like this dog, might have been this dog, that was on a long cable tied to a tree out in front of the house. The yard was unfenced. And as I would approach, the dog would bare its teeth, snarl, and lunge at me. And the cable would yank it back. So each time I ran by, I said hi to the dog. And I thanked God that there was a cable attached to this dog. Isn't that great? That dog can do whatever it wants. It's not going to get to me. Well, one day, all this happens per script, except there's no cable. So a rover takes off after me. I take off up the trail. I probably ran, a 10-second, 100-yard dash. And I didn't get bitten. I didn't get attacked. The next thing I noticed was my knee didn't hurt. And I was really shocked. I would have predicted if I treated that joint in that way, I would be lying on the ground writhing in pain. In fact, for the first time in probably 8 years, I was running and had no pain. I'd like to talk about another important aspect of the pain experience, which is context. Earlier in class, I talked about how our physical structure, our brains, always exist in relation to a larger picture. And our experience of pain or the absence of pain also always occurs and is dependent on the context in which it arises or it doesn't. So research has shown that if a patient is going to experience some procedure, potentially painful procedure, I'm hoping you're understanding now what I mean when I say potentially painful experience. That if the patient is there with an empathetic spouse, they will experience more pain. If their spouse is fairly self-absorbed, doesn't really pay much attention to what's going on with their husband or their wife, that person will experience less pain in the presence of their spouse receiving the procedure. How would we understand that? What would be the motivational factors that would lead to the brain's decision to create either more or less pain because of the context? Perhaps you've noticed that young children who fall down suddenly or who have their toy truck pinch their finger might first look over at mom or dad and then experience pain and start screaming, or, as has happened with my grandsons, see my reaction and start laughing, think that what happened was very funny. Why would that child's brain look to the parents to get vital input before creating an experience of pain for that child? What would be the motivational factors in this parent-child environment? What we do for a living is another vital context. So Lorimer Moseley has done work with many different professions, and things like paper cuts, superficial injuries to skin that we all experience in the course of living our lives. So what he found was that a violinist who experienced a paper cut, say, they artificially produce these stimuli when they're doing studies, will report more pain than will a dancer. I'll say that again. A violinist who experiences nociception in her hand, exactly the same degree of the next person who's a professional dancer, will report a higher pain experience. And if that nociception comes from the left hand, the violinist will report more pain than if it comes from the right. I play the violin, and I know that the left hand is the hand that controls the strings, as with most guitarists who are right-handed or cellists or something. And the demands on that hand are much higher than the demands on the right hand, which just needs to hold on to a bow as the arm moves it back and forth. So it makes some sense to me that the violinist would be motivated to report more pain or create more pain as a result of nociception in the left hand. Moseley also determined that less nociception was necessary to create that pain experience than it was in the right hand. So let's look at a number of other contextual factors here. We've talked about exercise. And certainly if I'm running 5 miles and experience a racing heart and pain in my lungs and sweating and flush, that experience will register as being very different than if I'm sitting on the sofa watching TV and experiencing those things. And if you've had a panic attack, you know it's completely possible to be sitting quietly, not moving at all, and experiencing all of that physical stress that we'd be experiencing when out running for 5 miles. So the meaning of that nociception, how we would understand it, is very different, even though the experience itself might be identical. Experiments have been run where the identical stimulus has been administered in a setting that had blue light and in a setting that had red light. In settings where there's red light, the participants would report more pain. This has also been done by saying to the participant, this will probably feel cold, or this will probably feel hot. If told this will probably feel hot, the same stimulus will create more pain. Why would that be? Why would the brain make that decision? It might be related to heat exposure in studies of Northern and Southern Europeans. So a Norwegian whose hand is placed under a sun lamp, say, will report less pain than will a Sicilian. Why would the Norwegian brain choose to withhold an experience of pain related to thermal exposure, whereas a Sicilian brain might decide to create pain? Just as the experience of pain is context dependent, so is the experience of analgesia. This would make sense if you remember the two-way street that is the spinal cord. Both pain and relief from pain are going to share some common characteristics, motivational, contextual, and so forth. And this is absolutely true with placebo. Placebo is another example of the way in which a substance that has no bioactivity, but which a person would ingest with an expectation that it would reduce pain, might well reduce pain. The data shows that 97% of the efficacy of antidepressant medication is placebo. The person is given a substance by an authority with the suggestion you might feel less depressed. That substance could be a pharmaceutical product. It could be a salt tablet. But something happens where the brain would take that input and decide, yes, you're going to experience less depression, or you will experience less pain. Studies have looked at acupuncture, which I have used when I've had joint pain or other kinds of pain, and I'm a responder to this. So I experience pain relief. Well, there's certainly some biomechanics, and Dr. Wisniewski looks a bit at the Chinese medicine chart and the way in which meridians are understood to produce wellness and disease states. We also know that acupuncture for pain relief is most effective if it's delivered by a Chinese man to a Chinese woman in China. It's least effective if delivered by a non-Chinese woman to a Chinese man outside of China. And then hypnosis is regularly used for analgesia in dental procedures and elsewhere. We can produce something called glove anesthesia, where a person could receive surgery to their hand, carpal tunnel surgery, say, and experience no pain. And here, I think we can see how the element of belief enters in, sometimes called suggestibility in medical hypnosis, that the surgeon would tell the patient, I'm going to hypnotize you and you will not experience pain as I slice through this tissue and repair this structure in your hand. If the patient is suggestible, that is, if she believes what she's being told, she will not experience pain. So while pain is our best friend forever, chronic pain is not. And it's a huge issue. So chronic pain occupies the first, fourth, and eighth positions in many lists of the top 10 global disease burden states. This is huge. The disability due to chronic pain far outshines the disability due to things like cardiovascular illness or diabetes or other disease states. And this phenomena drives things like our opioid crisis. This level of pain in the global population has driven a huge industry. And over the last 6 to 10 years, I'd say, we're beginning to understand the way in which chronic pain has created this new massive problem of opioid dependence. If we're not talking about these heavy duty, quotes, painkillers, close quotes, I'm hoping you can begin to take this language with a grain of salt. 100 billion aspirin tablets are consumed globally each year. That's a lot of analgesic, 40 tons. Placed side by side, those aspirin tablets would reach to the moon and back. And perhaps you can begin to appreciate how unnecessary and perhaps actually harmful much of this drug use is. It's built on this old model of pain that talks about pain receptors and pain messages and pain centers in the brain. And the fact that people are consuming this level of pain medication seems a quiet tragedy, as opposed to picking up the cognitive and behavioral tools that would actually strike at the roots of chronic pain states. I'd mentioned earlier that 1 in 5 of us walking around on the planet right now are in a pain state that's persisted for more than 3 months. That is a lot of people. And those pain states can include muscular pain, perhaps the most common, joint pain, very common as well, pain that is triggered in the nervous system itself, or pain related to skin injury, anything from paper cuts to, third-degree burns. All of these types of pain, if they are chronic, often defy a definitive diagnosis. Patients who are chronic pain sufferers often have the thickest medical charts because they have been sent from one clinic to another, sometimes for decades, searching for the origins of their pain. And the tests keep coming back negative. And if they're positive, they're simply imaging normal degenerative wear and tear in the human body. So all of us after a certain age, I think I would qualify for that category, show degeneration in the spine. The discs are compressed or worn. Now, few of us also experience chronic back pain. So when an image comes back that shows this degeneration, that actually does not give us any more information about the very real and sometimes excruciating experience of back pain. Unfortunately, there is an industry built around cutting, slicing, dicing people's spines. And the outcome data for those procedures is questionable at best. So we'll find this language traveling with this lack of diagnostic clarity. We cognitive scientists will talk about a psychosomatic pain, saying it originates in the psyche and is expressed in the soma or in the body. Perhaps now we can see that that's an artificial division. Psyche is soma. Soma is psyche. But what the term would point to is it's not tissue damage that creates the very real experience of back pain or pelvic pain or joint pain. It's something in the psyche. Conversion disorder was a term that was used quite a bit, less so now. And 2 suggests that a psychological reality is getting converted into a physical reality. And then there are labels like fibromyalgia, many, many others that are, at the end of the day, saying the pain is real, it's debilitating, but we don't quite know what to do about it. And in that not quite knowing what to do, unfortunately, patients are often wheeled into surgery or given synthetic opioids or quotes treated, close quotes, in ways that probably do not get at the roots of their very real experience of pain. Part of what happens in these chronic states is the body changes. So when we have been in pain for 3 months, there are structural and functional changes in the peripheral and central nervous system. So those sensory neurons in the spine actually get better at attending to and transmitting danger signals from the peripheral nervous system. And messaging that might have been disregarded there at the dorsal root ganglion prior to the chronic pain state would never have even been sent along to the brain, now gets sent along. The receptors for those messages actually increase in those cells. And similarly, those structures in the brain that receive and process those messages change and become better at creating more and more pain with less and less messaging. So these structural and functional changes amplify what is probably, in many cases, still normal nociception. Been sitting for a while, and our rear end starts to feel a little uncomfortable. So the nociceptors in our body are saying to the brain, hey, could be a problem. If I sit in this class for another 20 hours straight, I might do some damage to some tissue. And the brain would say, oh, that sounds reasonable. Let's create an experience of discomfort. See if we can get you up out of your chair. If not, maybe we'll turn up that experience. We'll move on from discomfort to mild pain. See if that gets you moving. So these changes reset the game board. And the old normal messaging now has a very different meaning and produces a very different output of increased pain sensitivity. So what can we do if we're in a state of chronic pain? One thing we can do is exactly what we're doing right now. We can acquire what Mosley calls pain literacy. It's like acquiring emotional intelligence, understanding the role that emotion plays in our lives and what position we can take to different emotional states. So information, I think, is a starting point, particularly if we're still wedded to an old model of pain that would keep us locked in a helpless and hopeless position. Understanding what's really happening in our brains and bodies when we experience pain for an extended period can begin to open some doors for us. So I'm hoping that one of the doors that it's opening for all of us right now is the understanding that pain is not something we passively receive and have to live with or try and buffer. It is something that we all do. It's the final output of choices that we're making at many levels of the body and the brain. And if we want to do something new, we can. This is a deeply hopeful and empowering change of perspective. I no longer need to be a passive victim. I can be an active agent in my own healing and recovery from chronic pain. An important piece of our literacy is understanding that the brain has a negativity bias, we could say. So the brain will receive the nociception and make a perceptual inference about what it means. The brain tends to err on the side of safety. We could say the brain is conservative. It wants to conserve tissue, function, wellness. So it tends to perceive the incoming data with this goal. I want to make sure I minimize damage and maximize wellness. And because of this bias, the brain may conclude false positives, interpretations of data as being dangerous, when actually it's not, is acceptable. Better safe than sorry, the brain might be saying. So this is true in 24/7 for all of us. There is this conservative position when it comes to interpreting nociception. It becomes much more true if the pain is chronic. The brain will become more and more conservative and make sure that less and less movement of an injured limb, say, produces more and more pain. So how can we exit this cycle? How can we heal ourselves? You may recognize that this template is exactly the template that we referenced when talking about healing from other chronic states, anxiety or depression. We talk about human suffering. That experience is processed in many of the same brain regions. Brain doesn't distinguish the pain of lost love from a sprained ankle. It's pain. And we experience the pain because the brain perceives that will be protective of us and our wellness going forward. So the first step we'd take would be to recognize, I don't want to do this anymore. I may have been in a chronic pain state for 3 months or 3 years or 30 years. These states can just travel with us through time, but I don't want to do that. So then we would reach out, we would work with the provider. Many providers. I work with people who wish to reset chronic pain states. Physical therapists work with people, physiologists work with people, acupuncturists, yoga therapists, huge cadre of potential companions on the road out of chronic pain and into healing. So in consultation with our provider, we would say, we're going to reset what's happening here. We're going to reset it in a couple of ways. One, we're going to reset it cognitively. This would involve addressing the thought patterns, such as, I just can't move like I used to. Or if I tried to walk to the store instead of taking my car, I would very likely never make it home. So we can analyze, do these thoughts contain distortions? You may recognize from last class, that last thought had a lot of fortune telling in it. I know the future, and the future is very bad. We can also work with cognitive viruses, but actually turn them into antiviruses. So if we start by imagining walking to the store and imagine emitting that behavior and feeling low levels of pain, we're going to begin to rehearse cognitively a different experience of that behavior. So when I'm working with people, I want them first to have an imaginal exposure of being able to walk to the store or to lean down and tie their shoe, or whatever it is that they've been avoiding doing, and be able to imagine doing that painlessly. You can see how we're starting to fire some new neuronal structures. And as those fire together, the probability that they'll start to wire together goes up. Imaginal exposure or imaginal rehearsal is part of healing pain. It's also just part of increasing performance. Athletes imagine shooting the ball and having it go through the hoop, or connecting with a fastball and hitting a home run. We'll also behaviorally challenge the old neuropsychosocial tags. Lorimer Mosley's term is a neurotag. It relates to the neuronal activity in the brain that would make us more likely to experience pain as an output of the brain. I'm going to talk to Lorimer when I see him next and say, how about if we say the neuropsychosocial tag? Not only resetting what's in the brain, but what's in the body and what's in the behavior and what's in our relationships and our work lives, etc. So we will, as one of our students earlier told us he had done yesterday, challenge a thought or a belief that I can't do something. Well, let's find out. Let's go and get some data by which to evaluate our perceptions of our limits and of our capacity. So on the behavioral challenge side, we may design an experiment. And I've worked with patients who have been housebound because of chronic pain. The experiment might start with, can you walk outside and stand on your front porch? Let's start there. What happens? And let's measure how much pain that produces in you, and if that pain persists or is rather quickly gone. And then let's walk down to the sidewalk, get the mail. You haven't gotten the mail for 2 years. Let's walk down there. We may have to address those distorted thoughts about I'll probably trip and fall and be unable to get up, and my husband won't find me until I'm frozen dead outside the house this evening. Maybe may need to do some cognitive work along the way, but let's see, can you go down and do that? And then, okay, it seems like you can. Now, how about walking around the block? Haven't done that for years. An important part of setting up these experiments is I would invite the patient to perform up to a certain pain threshold. And we can quantify that. We can say if the pain scale is 0 to 10, you would emit the new behavior, continue to walk up till some number, say an experience of pain at 4% or 40%. And then you stop. You don't keep going. An error we make when we're in a state of chronic pain, I think I made this for years when I continued running. I said, well, I'll just push through it. I had athletic coaches who encouraged us to do that. Oh, you're in pain. No, don't pay any attention to it. Just keep going. Well, perhaps you can see how that will keep us stuck in this chronic cycle. Because when our pain goes up above whatever that threshold is, the rest of that psychosocial neuro pain tag will kick in. And now we're practicing being in a state of chronic pain. We're not practicing living a pain-free life. So there's a very fine line that we're looking to walk here. I had rotator cuff surgery a while back, and I worked with a physical therapist, and he helped me quantify this stuff. Daniel, I'm going to ask you to start moving your arm. We're going to take it out of the brace, and I want you to tell me how much pain you're in. And then he would give me feedback and say, huh, okay, that sounds like normal pain. I want you to keep doing that movement. Or he would say, oh, that pain sounds like you're starting to threaten some tissue. I'd like you not to do that this week. Or I'd like you to continue lifting the 2-pound weight. Don't go to the 4-pound weight. I don't think you're ready for it yet. And I worked with this fellow, followed his directions, and am now pain-free after having lived with shoulder pain for many, many years. So collecting data is an important part of the healing journey. We can't do this seat of the pants. We have to measure stuff and say, here's my level of pain when I'm in motion at this level. And then perhaps with the help of a skilled provider, analyze the data. What is that saying to me about this program that I'm on? Do I want to step it back? Do I want to stay where I'm at? Do I want to turn it up? And it's in working in this way, in this zone, that we can reset that bioplasticity that created the chronic condition. But now the bioplasticity is working for us. We can change all of that stuff back, or we can actually change it into a better position than it's ever been in if we're working in a skilled and intelligent way. I hope that you enjoyed this presentation. If you did, consider subscribing to this channel or checking out our weekly online consultation and training program, All Things CBT.